much. Now we will move to our third speaker. So Dr. Zahid al-Mandari. Dr. Zahid is a radiation oncologist and a member of the National Bioethics Committee. He headed the Bioethics Committee in Royal Hospital, where during his tenure, he introduced unique approach to evaluation of the different bioethical dilemmas. Dr. Zahid will be speaking about the ethical consideration in vaccine deployment. Dr. Zahid, the floor is yours.
Thank you very much. So I'm going to start my talk on some very controversial issue, which is the ethics of vaccine deployment. I'm going to touch on autonomy. I'm going to talk about anti-vaxxers, mass vaccine policy. I'll touch also on vulnerable groups, and I'll have some recommendation and action points. So I'll start right from the beginning. Basically, we know vaccines work. If we put into consideration that vaccines have been around for more than 200 years, well, you know that millions of lives have been saved. And the only diseases we've actually been able to eradicate are those that we have been able to vaccinate, and that's smallpox and polio, which is just about to be eradicated. So you look at this graph where there's a comparison of the annual morbidity in the 20th century versus 2016. You can see that vaccines have made a huge impact. But with all this data, why is the movement of anti-vaxxers increasing? Anti-vaxxers are basically the movement of people who are against vaccines. So
please put slideshow. Your slide is not shown.
Oh, okay. Sorry. Is that okay?
Not yet. Share screen.
Okay, 1 minute. Share screen. Okay. So if we look at this graph, my slide is seen right now? Yeah. So if we look at this graph, basically you see that in the 20th century versus 2016, vaccines work. But the anti-vaxxers momentum is still gaining movement. A study that was done in 2016, where 67 countries were surveyed, titled "The State of Vaccine Confidence," showed that 5.8% of the respondents globally were skeptical about the importance of vaccines. And in some countries, that was as high as 15%. And that was in 2016. We know that between 2016 and 2020, this movement has gained even more momentum. So with all this data, and that's there, why does the anti-vaxxer still have good momentum? Well, the first point is that the reasoning behind why the diseases have gone down is they say that, well, hygiene has improved, nutrition has improved. That's why the infections have gone down. So that's a good point. But given that because of this movement of decreased vaccination, we're now starting to see a resurgence of disease where we still have good vaccination and still have a good diet. So that sort of counters that notion. But then the biggest notion is basically the risk-benefit ratio. And one of the biggest concerns for the anti-vaxxer movement is that vaccines can cause autism. And there are three major theories behind this, but there are multiple studies that show no correlation. But not just the studies, there is independent reviews of those studies that also show that there is no correlation. But what's happening is that to translate that into influencing skeptics has become a huge issue. And the reason is this. Basically, we start to see that there is mistrust, and the mistrust is mainly in big pharma. We know as doctors that the pharmaceuticals always do this, where they the distribution is limited to certain countries and so on for certain drugs, especially now with things like remdesivir, where certain countries have actually bought huge amounts of this drug and hoarded. And so this is more towards the protection of distribution rights and to make sure that these medications reach the group that they're intended to. But on the flip side, you get a message saying, "Wake up, Africa! This is not a cure; it's a trap that can kill you, and use you as a laboratory rat." And this is where the social media is starting to play an important role, and building mistrust and disinformation. And most of these viral messages have a certain recipe where they bring certain truths into the picture and they mix those truths with false information. And it's normal for a human being to look and see, okay, I can buy remdesivir. I can see that it has this tag here that says not for distribution in certain countries. So if this is true and the logo is true, then probably what they're saying about using us as lab rats is also true, which is what the recipe for disinformation is always. You'll find that many of the viral messages have disinformation as well as some truths. It's not always lies. If it's all lies, it's usually discarded from the beginning. So, and even if we look at the economical impact of vaccines, we know that there's a nice study actually that was done that looked at 94 countries of low and middle income countries, and that estimated that they paid around 34 billion for immunization programs, but resulted in 586 billion in reduced cost of illness and 1.53 trillion in broader economical benefits. So really, vaccines do help. So now the question is, where does autonomy fit? Obviously, everyone has a right to make a choice. But when vaccines not only provide individual protection for the persons who are vaccinated, but they also provide community protection by reducing the spread of disease within a population, that becomes a big question. Here you see in group A, where there are people who are vaccinated, but the vaccination rate is low, but and the transmission of disease does happen. When you compare that with group B, where the vaccination rate is much higher and the disease transmission is interrupted. So you just have to think about that. So let us just take an analogy of a boat where you have people which is sailing on fresh water, and you have lower deck passengers and upper deck passengers. The lower deck passengers, when they want water, they have to go to the upper deck. And if the lower deck passengers say, you know what, let's just make holes in the lower deck and see, and we'll get water, we're not going to harm any of the upper deck passengers. If we let that happen, then the ship will sink, and the people who are on the upper deck, even though they were not involved in creating that hole, will also sink, and they will not reach their destination. So that's a very, very important analogy when it comes to when community well-being is at stake. Where does personal choice fall? So that's where we sort of start to talk about the social media and the role of disinformation. And what I've seen now with Twitter and Facebook is that they're actually starting to censor disinformation. And that's where this sort of role of oversight on what is true and what is not. Obviously, there's a debate as to who has the right to decide what's best for the whole community versus someone else. So that debate is obviously there, but it's the same analogy as the boat, where someone has to stop someone attempting to put a hole in the boat, or the whole boat will sink. So can we afford to force vaccination? Obviously, if we can't, what are the alternatives? And alternatives, there are many. Some are also controversial, while others are less controversial. So nudge is a technique that has been used, and basically you basically guide people in order to take the vaccines, and that's by using things like fines, limiting services. For example, travel. You wouldn't be able to travel if you're not vaccinated, or you wouldn't be able to go to school if you're not vaccinated, or charging for treatment. For example, if you opt out of a vaccination and you get sick with that particular disease, then you'll have to pay for treatment. Otherwise, if you don't have to pay for treatment. Or reverse consent, where everybody has consented except those who fill a form and go and basically state that they don't want the vaccine. So this is kind of, it's very controversial, and talking about nudge ethics is beyond the 15 minutes of this talk. But what's better than nudge, obviously, is campaigning. And just like how for disinformation is becoming widespread, we really need to have a campaign talking about what is the good, what is the bad, what is the ugly of the vaccines. And I have to talk, when you talk openly and you're transparent, that's when you start to gain a trust. And transparency is really the key here. And you have the Oxford vaccine that basically stopped. It's one of the major vaccines that had huge hopes, with countries that have actually started pre-production to basically prepare for deployment. And you can see that they stopped the study basically because they want to evaluate something that has happened to one of the participants. So this type of transparency is required in order to start to gain trust with the public. So when it comes to the deployment, assuming that we've had very good campaigns and everyone wants to be vaccinated, supply is not going to cover demand anytime soon. And we know that, and that's a fact. So who is eligible and who can be vaccinated first? Dr. Laura or Professor Laura has covered this briefly, talking about the frontline workers and high-risk individual, basically those with the highest exposure or the highest risk of dying will be the first, and then that basically goes down level by level as the phases go. So I'm going to share with you an example of a policy that was deployed by the National Academy of Medicine Committee of Equitable Allocation of COVID vaccine. This was in the US, and basically they chose a similar approach with phase 1 frontline workers. Makes sense. All the adults living in crowded, congregated settings, again, makes sense. People with significant illness at high risk of illness and death. So that was phase 1. Then phase 2 goes towards more of the essential workers who cannot do telework or working from far. Things like teachers or schools that are not going to be teaching or teleschooling. People with illness at moderate risk, and so on. So basically the level of phase 2 goes down. Then level 3 is more of an economical recovery, looking at vital workers in occupations with moderate and low risk, basically who, if they go back to work, then the economy is very likely to go towards the recovery phase, young adults and children. And then finally, phase 4 is for more of the individuals interested in receiving personal protection. But again, they say here personal protection when we know that it's not just personal protection, it also provides protection to the community. So there are things that we need to look at when you look at this, this deployment. And I'm not saying this to be critical, but although from the same report, they did mention that people of color have been disproportionately sickened with COVID-19, but the report did not recommend listing Black, Hispanic, or Native Americans as distinct priority groups, which kind of, we talked about some of the priorities and vulnerable groups, and maybe you need to rethink of that. If you're a country preparing a policy for vaccination, you should be looking at the vulnerable groups. So that's one thing to look at. But then we also have to look at the safety of vaccine in elderly and children. That's an important topic. And that was covered a bit on the first talk, basically with the children and pregnant women. But in the studies that have looked at vaccination, most of them have been in the age group of 18 to 60. And we know as you go above 60, the risk of dying from the disease is much higher. Although some studies did open the door for studies above 60, they did have stringent criteria, meaning there's no comorbid disease, et cetera, which kind of limits the number of people who can go into those groups. So we need to be extra careful interpreting the data when it comes to the elderly and children. So this brings me down to the final recommendation. So really, what we need to do is first, we need to curb disinformation campaigns. And we also need to have our own early campaigns. I know vaccine is far away, but we need to start that very soon and we need to be very clear about the benefits of vaccine versus the risk. We need to be fully transparent about the good, the bad, and the ugly of the vaccines. And I thank again Oxford, the vaccine group, for for being transparent and stopping the study. And we need to also to continue to share data while vaccines are happening, saying, for example, that 10% of the population has been vaccinated, so far no side effects, etc., or we had minor side effects of fever, etc. These are things that the public need to know, and that basically builds the trust. And finally, we need to develop clear guidelines of who is to get vaccinated, and to take into consideration minorities and vulnerable groups, and be cautious about the vaccines that haven't been tested on the very young, very old, or the pregnant, and keep an eye on data that's emerging from this particular group. Thank you.
Thank you very much, Dr. Zahid, for a very elaborative, comprehensive coverage. And now I will move to the final presentation. Our